Good afternoon, or evening almost for some, to our Culturally Aware CF Care Symposium. My name is Chandra Gordon. I'm a pediatric social worker at the University of Kansas Health System.
All right. Hello, and I am Chloe Ford. I am actually the owner of Thereafter Therapy, which is a mental health practice which specializes in CF, and also the former CF social worker for Ann and Robert H. Lurie Children's Hospital in Chicago.
Great. So this afternoon, we're glad to have you here to be able to be a part of various discussions and presentations as it relates to the cultural diversity of individuals living with CF. Our hope for today is that as you sit and listen to each of these presentations, that we look at diversity through different lenses. And when we walk away from hearing what we're hearing today, we hope, and I'm going to say pray, that we all have an opportunity to think about what can we do to be more culturally responsive, to be more culturally aware, not only for the patients and families that we serve, but just overall humanity. Our hope for today is really to open our eyes, heart, ears to what is going to be shared, and we hope that we have invited our speakers to be able to take us on that journey today.
All right, so before we get to our speakers, we just wanted to share some data with you that we received. The CF Foundation Quality Improvement and Innovation Department provided us with data regarding, and this is the national data for the Experience of Care Survey. And for those of you who do not know what the Experience of Care Survey is, it is a survey that goes out to the patients and families after their clinic visits to just know about their experience. So it assesses just what their overall experience was about clinic, to just know what we should be doing better, what we can improve on, and then what we're doing well so that we can continue. As you can see, 3,597 completed surveys were a part of the data that they separated by race and ethnicity. And then they showed the 83% of respondents, the breakdown based off of race and ethnicity. So the first question that they asked, they noticed that there was a difference in the responses that they were receiving from patients and families about their shared, about their experience with contact for care concerns, and then after leaving a visit, feeling as if they actually had a plan that fit their family. In addition, there was a difference in how participants reported being having a co-production, and so knowing that there was a partnership with their CF care center when they're left, and having that positivity relationship, that positive relationship. There was also a difference regarding the infection prevention and control practices. So overall, what does that mean? When they looked at this data, they started to realize that, when they looked at this data, they started to realize that it raised questions to the comfort as well as the cultural sensitivities in sharing feedback. And by that we mean that from the data, they had to inquire if people were feeling comfortable answering the questions that they were getting after the clinic. Because although it is anonymous, they had to say, did people believe that? Did they actually feel like they could be honest with their feedback? Or if they were truly honest with that feedback, would that change their care? Would that change the relationship? Would that change the resources? And so are they just telling us what they want us to hear? And then if they do that, how can we truly serve our patients and families the way that we should serve them? So now they're trying to figure out, how do we best give this survey and truly receive honest feedback from our patients and families? How do we make them feel comfortable with giving us that information so that we can be our best for them? So.
Other initiatives have taken place as well in order to understand the lived experience of individuals living with CF. In November 2020, there was a survey conducted It's called the CF Foundation Communities of Color Report, for those that are not familiar. In that survey, 75 responses, and that included adults with CF, spouses, as well as parents and caregivers. And through the analysis of that information, 3 primary themes emerged, and it all related to representation, healthcare provider bias, and trustworthiness. So throughout our presentation, in between each presenter, we're actually going to bring the voices of those individuals to our session as well. We feel that those that can attend and hear, we're grateful to have as a partnership, but for those that could not be here, we still want their voices to be heard. So I would like to bring forth our first speaker for today. He doesn't need any introduction.
No introduction.
No introduction. All right.
When you have a visible disease, people look at you, but they do not see you. When you are a minority in this country or in healthcare, people look at you, but they do not see you. When you have both an invisible disease and you are in healthcare, many people will look at you, but they will not see you. However, so often, those people, they do not feel that they're in a place to be heard. They do not feel they're in a situation where they can speak up. They do not feel that they're in a situation when they tell people they are not seen, that they're in a safe space to make these claims. Well, today, this will be that safe space. With that being said, my name is Nicholas Kelly, and I will be your speaker today for the lived experience of culture and race. So, who is Nicholas Kelly? Minus a man with fabulous curls. That's right. Took a lot of things to get these things right. So, I am a registered and licensed dietitian with my master's in food nutrition. I am a speaker, an author, an artist, but most importantly, I'm a 35-year-old male living with cystic fibrosis. So, those are some interesting facts about me sitting there. You know, fun facts about me. I have a twin sister. I'm allergic to watermelon. Because of this session, I can say I'm really happy to tell people that. Like, it really makes me so happy to be able to tell them, you want some watermelon? I do not. I don't have to tell them why. I just like to tell them I am not eating that today. I went to Paris for my 18th birthday, which is important. That'll come up in a second. And then I went again for my 31st. Random. I have an extra vertebrae. Most people have 6, I have 7. That's only important because at my center, when we say when something weird happens, Nick happens. There's a couple of you in the audience who could justify that. And then I'm gonna let you guys read that one on your own for a second. I know, right? When it happened, like it started and like I pushed it open and like jumped out like The Grudge, and like she had the audacity to be mad at me. Like you started with me in there. So I am more than my diagnosis. I was a professional dancer for 12 years. As I mentioned, speaker, poet, photographer, and DJ. So today I want to take you on a journey. As we look at this journey, I want to have the conversation of both professional and personal incidents of where race and culture have not only played an important part and an integral part in what I've been able to accomplish, what I've been able to do, it also has provided opportunities for growth, opportunities for information, and merely opportunities. So I have to go no farther than my born childhood. So as I mentioned, I was born March 16th, 1987. I'm a Pisces. Any other Pisces in the room? There we go. I mean, it's a little stain. We're all on this side of the room because we know what it is. All right, Team Pisces, high five there. So I was a very sick child. Not uncommon. And no one knew what was wrong with me. And when I say no one, not really no one. Why? Because it was actually my mother who diagnosed me with CF. Why? Because 35 years ago, they didn't think African Americans can have this disease. The problem is, even today, that rhetoric still exists. That thinking, that information still very much exists. And so because of that, it has put me in a situation where early on, I knew tenacity, I knew fierceness, I knew advocacy. Fast forward to my 18th birthday. I got the gift that every teenage boy wants, diabetes. Yep, that is how it happened. On my 18th birthday, I got diagnosed with diabetes. But I'm gonna set the stage for you all so you guys were there. I will say, the names have been changed to protect the innocent. Little Dragnet reference, you might be too young for that. You know, that's adult stuff. You guys, ask your parents if they don't know. So one of those things was I was sitting in my hospital room because I was admitted at the time, and endocrinologist comes in and goes, Nick, your sugars are still high, they're not coming down, so you've got diabetes. We're gonna start you on insulin absolutely now, today. That's all we got? That's it? Okay, insulin today. Now, that was how it was presented to me. Flip side, as a patient, how did I take that information? I was like, oh, diabetes, no, because let me talk about culturally what that means to me. Growing up, you heard you had diabetes, you immediately thought, I'm going blind or I'm gonna lose my foot. One of those are my scenarios. So also, what we knew as growing up, if I had the sugars or I had the sugars, we were in a situation where I have this thing that is immediately going to change. I also knew if you had to take insulin, that means you had the worst version of diabetes. So now I'm in a situation where I have this disease that I'm gonna lose my feet, and I had the worst version because I immediately. And so now I'm in a situation where, wait a minute, this feels like a gross overreaction. Because I was on prednisone, and all I know, that made my sugar high. So I don't have diabetes, let's stop the prednisone, and let's relax, people. Weird reactions, remember, Nick happens. So let's first relax. Next, I was thinking, I don't wanna go straight to insulin, because that's the worst version. I've heard diet and exercise works. I'm willing to get fit, drink it in, I know, right? And I already take a bunch of pills, one more. Now, that's the conversation that would have took 2 minutes to have and would have changed exactly how I approach my diabetes. But that's not the conversation was had. I was told that initial scenario, and that's how it was told to me. So I'm gonna be honest, I pushed back. I pushed back against this idea. Because in my mind, I thought I can stronghold myself into getting the care I thought I wanted and I thought I deserved. If I don't take this insulin, if I say no, then maybe they'll allow the pills and the exercise. All you had to do is let me know, hey, that's not how this works. You don't have the worst kind, you just have a kind that can't be treated the way you would like to. See, one sentence. Prednisone didn't give you diabetes, it just kind of unlocked the door. Oh, that's it? Oh, okay. I'm smart, I can recognize that. I doubled down with this same clinician not many years later, decided to write a letter to the board of healthcare and Medicare and said, this patient is not disabled because when given the opportunity to get better, he chooses consistently not to do so. Yeah. I was then denied disability for 5 years because of that letter alone. I say this because it presents an opportunity that one conversation could have changed everything. They chose not to have that conversation. Professionally. So I want you guys to take a strong look at those numbers real quick. I am a dietitian, as I mentioned. 92% of this profession is female. Of that, 80% is white. That means 80% of my entire profession is Caucasian female, generally type A. I don't make the stats up, people. I just tell them. I just tell them, okay? This is what it is, okay? I didn't make this up. Google it if you don't believe me. This is really important because, one, the only profession that mirrors this kind of disparity is engineering. However, the problem is even the males across that are much more diverse. I make up less than almost about 1% of my entire profession. How does that affect my professional life? So I'll give you guys another example. I'll set the stage. It was a gloomy night on a Wednesday day. I was a part of a panel and I had another dietitian on. So we're doing our pre-panel calls, we're working it out, and then they tell me, towards the end of the meeting, they ask, do you guys have any input? My statement is, how are we gonna account for cultural differences, race differences in this talk? I know this talk is more about general nutrition, but this feels like an important part of nutrition. My dietitian cohort responds to me, well, to be honest with you, that doesn't matter because all that matters if you're a good dietitian. Lucky this call when I said this was at the end of the call. So I didn't get a chance to make my piece or read her the riot act. But it was very clear, like, oh, is that what you think? Come back to our next call. This one, I'm geared up. We starting the meeting off with this one. We start the meeting off with her saying, hey, I want to start off by saying, Nick, I want to apologize to you. I'm like, carry on. She then says, I found out our moderator had mentioned something like you weren't happy about my statements. And so what I did is after I was told this, I went and did research. And do you know these disparities exist? Yes. And she was like, I just couldn't believe it. I did so much research and it's consistent across the board in nutrition, all areas of healthcare. They just exist. And at this point, she had like a thesis level paper she was ready to explain. I was like, I appreciate the enthusiasm. We can't go through all of this. Our session's not long enough, but I appreciate you. And I want to thank you. She's like, well, I'm thanking you. Well, let me explain why I want to thank you. Because you are the gold standard. Initially, I made a statement, you push back, that can happen because I'm challenging your fundamental way of thinking about the things you've learned. But you then took the initiative to do the research and learn and came back and said, okay, now I'm ready to have the conversation. That's all we can ask of any of our clinicians, patients, people. Learn, do the research, and then let's have a conversation. Or present the questions after you've done some research and say, okay, I don't know. Spaces like this are where you ask the conversations, you have the questions. Because as I told you, this will be our safe space today. So, another example, set the stage. I was working as a dietitian, and I love students, I love teaching. So anytime I have the opportunity to take on a student, I am 100% going to do that. So I was working at a place called Barnesville, Ohio. The name is called Barnesville, you guys can imagine where it is. Just get past that. Like, I don't know Ohio, it's called Barnesville. Use your imagination. So I have a student, she comes in, hey, we're gonna go. I was like, all right, well, my teaching style is, I'm gonna let you be the person. Go ahead and be everything. I just kind of hang out in the back with a little clipboard and pretend like I'm busy, and that's just have it happen. So we walk in a patient's room. I'm standing right here. She's right there. She's giving her lesson plan. She's talking to them about the care. And she makes a statement. Now, this statement was not egregious, but it was a situation where a young dietitian or a young student is easy to make. An experienced one would not make it. At this point, I'm experienced. I've been a dietitian for over 10 years. So I go, hey, actually, well, we don't really do that kind of care. It would actually be better if we approached it like this. Patient looks at me, John Doe looks at me and goes, yeah, we don't really want to hear from students, but we're going to listen to the dietitian. We appreciate it. Big bet. Say less, my guy. So I shut up. I'm going to stand back here. I've said my piece. I let her go back to doing her thing. Another statement is made. I'm like, well, actually, the best care plan is going to be X, Y, and Z. More annoyed this time, and his wife looks and goes, we don't want to be rude, but we're not going to tell you again. We don't need students right now. My husband's very sick, and we need someone who knows what they're doing. So we appreciate you, but I need you to be quiet now, or you can leave. I then go, okay, you want to hear from the dietitian? So actually our care is going to be, what we just say? Oh, we did say, oh yeah, I'm sorry. I'm Nicholas Kelly, I'm the dietitian. This is my student, Miranda. Crickets. So I go, they look at me, I look at them. The student kind of gives a nod like, oh yeah, he's a dietitian. And we sit there. Now for me, I've experienced this more times than I can count. Over and over. Doesn't help, I also look like young, so I get that Doogie Howser thing. Over and over. However, for me, I didn't need this experience. I've had it already. I needed her to have this experience. I needed her to realize not only does this happen, we can react in certain ways. I could have easily shut it down very early. When I walked in, I could have been like, hey, this is dietitian, this is. Hey, we're both learning nutrition, we're both your nutrition professionals. That's how I presented it. I could have easily shut it down at any moment. I chose not to. Why did I choose not to? Because I wanted her to have that experience. I wanted her to be uncomfortable as she stood there and looked and saw what those people, the perception they had. I wanted her to look and say, really, this is the experiences I didn't have before, but now I have. I'm not sure how I'll react in the future, but I saw how he reacted. I saw the poise, the grace he reacted. Because as many of us know, I'm a representation for everyone who looks like me in every field I'm in. So I needed her to understand that I will gladly be the example. This is the thing. More often than not, we don't take the time and realize these examples affect all of us. They affect our patients. They affect our health systems. They affect our other clinicians because I'm a patient, I am a clinician. But what about your colleagues? We hear the word microaggressions. What does that really mean? It means people often of minority working spaces, especially this space. It's not just the patients who are predominantly white in this space. Those coworkers have to work in these spaces. So are they getting it? Do you have to wait for someone smart to retire so your voice can be heard? This is the thing. Having those things, having those conversations, we need people to understand that in these moments, it is not my responsibility, it's not your responsibility, it's not your responsibility. It's everyone in this room's responsibility to have the conversation, to make people uncomfortable, to hold people accountable, to say, I will not just be here today, I'll be here tomorrow and I'm gonna show up for you tomorrow. Make your colleagues be better. Make your friends be better. Make the people around you be better. You do not have to be the one to try to change the world. Just change the person next to you. And if everyone did that, that's over 1 billion people changed. Do the math, do the numbers, because this is the way that we're going to change. Understand, the most important part of any journey is the steps you get there and the people who help carry you there. What person after today wants to help carry me to the next area? What person wants to help carry their next person to the next area? Strong shoulders, strong back. We are bold, we are strong, we are better together. But the only way we can be better together if, drum roll please, if we're together. Be the change you wish to share in the world. Be the change you wish to see in the world. And in this world, in this day, in this day, in this day. So understand, in this day, let every space be a space place. Let every place you go be your space place. Why? Because make everybody uncomfortable, and maybe then we'll get some real change. I am Nicholas Kelly. Thank you for your time.
Q&A. Questions? All right. So we do have about 5 minutes. If there are any questions for Nick, we have it through the app, or we also have microphones available.
I mean, if no one has questions, I'm okay just standing here looking pretty. I'll model this, shameless plug. This is actually my shirt, so yep, there we go. I'm just gonna stand here until we get some questions. Somebody got some music, maybe I'll break dance a little bit, a little 1-2.
Well, if we don't, definitely may have time at the end. So if anything comes to mind, we definitely want to share that. Thank you, Nick. Get the clicker.
All right, before we bring up our next speaker, we just wanted to take a moment, as Chandra had said earlier, we had received quotes from the community, and we just wanted to take a moment to read some of those quotes to continue the voice of those who are not here with us. All right, so just taking in how people have felt about representation within this community. And now our next presenter, Dr. Jennifer Taylor-Cousar, Dr. JTC. She is the president-elect for medical staff, medical director of clinical research services, interim associate vice president of diversity, equity, and inclusion, and co-director and CFTDC director for adult CF program at National Jewish Health in Denver, Colorado. Dr. JTC will present on racial disparities in healthcare and bias in medicine. Now, before we begin, just remember to put your questions and comments, find session S32. But please help me in welcoming Dr. JTC.
I'm at the blame moderators for putting me after Nick, because who can follow that, really? Thanks again, Nick, for being so honest. So I am going to not be nearly as funny. I'm going to be very serious, so just get that hat on right now. I'm going to talk about bias in medicine and the racial disparities in healthcare and how we got there and where we need to go next. These are my disclosures, most of which aren't really relevant exactly to this presentation, but I just want to make people aware. And I also want to directly address this slide. So many of you may have seen this slide in various presentations at this conference, at the ATS conference, at the CHEST conference. And I think that what it represents is the request by a number of people to not just talk about diversity in the DEI sessions, but if we're really working towards diversity, inclusion, and justice, then that lens needs to appear in every single thing that we do. And so I, as a leader and as someone who does serve on committees, commit personally to making sure that we are putting that lens on everything that we do. So the learning objectives for today are to understand the contribution of racism to the social determinants of health, to recognize that historical and ongoing racism in the medical system impacts diagnosis, as you've heard, it impacts treatment, and it impacts health outcomes for people with CF. And then to describe the changes that one you can make. You already heard from Nick, one of the things that you can do, look at yourself and try to be that change. But I'm going to give you a couple of tips. And I apologize that my voice is scratchy. I've been speaking a lot over the last couple of days. So all of us went into medicine, whether it's in nursing or nutrition or social work. We went into medicine because we want to help people. But unfortunately, the education that we received in grade school, in high school, in college, in our medical training is inadequate to properly take care of all people with whatever disease that they have. And so we need to educate ourselves to be better. And so in the great words of Dr. Maya Angelou, do the best you can until you know better. Then, when you know better, do better. So I think I need to make sure that we're all on the same page starting out in this conversation. So it's really critical that you realize that race is not biologically based. It is a social construct. So it's a politically and socially defined category. So Dr. Svante Pabo, who's director of the Max Planck Institute for Evolutionary Anthropology, said, even between Africa and Europe, there is not a single absolute genetic difference, meaning no single variant, where all Africans have one variant and all Europeans another one, even when recent migration is disregarded. And then Dr. Michael Udell, who is a professor of public health, said, if you make clinical predictions based on somebody's race, you're going to be wrong a good chunk of the time. For example, cystic fibrosis, which is underdiagnosed in people of African ancestry because it is thought of as a white disease. It's thought of that way because we taught it that way. In the US, obviously, we do have these socially constructed categories. And even the US Census says the racial categories included in this census questionnaire generally reflect a social definition of race, recognized in this country because it varies by country because it's socially constructed, and are not an attempt to define race biologically, anthropologically, or genetically. But nonetheless, we have these categories, so I'll explain what they are. So these are the different race categories that we have here in the US, and they're basically defined based on physical characteristics. Ethnicity in the US is either Hispanic or not Hispanic, and it basically is supposed to be looking at cultural definitions, language things, even though people from Brazil are considered to be Hispanic even though they speak Portuguese. So again, you can see how this doesn't make sense because it was socially constructed. So even though it's a social construct, it's critically important that we talk about it because race often serves as a proxy and as a determination of the social determinants of health which impact people's health. Now, I want to give you a concrete example. So I'm not sure how many of you are familiar with the concept of redlining. But again, looking at things that the US government has done, they actually defined different neighborhoods and gave them grades based on really the color of people who live there. And so green was the best, that was an A grade, and red was the worst, or a D grade, where mostly Black and Hispanic people lived. And so they gave these grades, and that determined who could get loans. So if you live in D, you are much more likely to not be given that loan. And also, confined in that area even after desegregation was supposed to have occurred. So again, put into law, this is a systemic problem. It didn't just happen out of nowhere. But going forward, a group of researchers just recently, as of I think last month, published this report looking at people with asthma and their severity and linking it to the many, many year practice of redlining. And what they showed, I don't want you to read all this small print, but essentially every marker of the severity of asthma was worse for people who lived in redline neighborhoods. So these things that happened a long time ago continue to have repercussions today. That's greater society. What about medicine? So this group, Dr. Williams led, put this in their article, Racism, an organized social system in which the dominant racial group, based on the ideology of inferiority, categorizes and ranks people into social groups called races and uses its power to devalue, disempower, and differentially allocate valued societal resources and opportunities like healthcare, and it's evident in medicine. So how do we get here, and how do we get past that? I think it's really important to realize how much bias all of us have. We're inundated with things from the time that we're little, in school, in the news, on newspapers, I mean, just everywhere in life. And I could talk about that all day long, but I think this video actually really shows how problematic that it actually is and how early it's ingrained in people. Oops, if I can get it to play, let's see. Where's my IT guy? It was playing in the room. It's advancing and stuff.
It's a screenshot. It's not, I don't think it's linked to it. It's a screenshot. It's not.
Yeah, I checked in the room before we got there, but it's okay. We have to skip it. Okay, well, I would encourage you actually to go on YouTube. I'm sorry that it's not playing. It actually played in the preview room. But essentially, what this test was called the black doll, white doll test. And the researchers showed these dolls to these children and asked them about which dolls they wanted to play with. And almost all of the Black children chose the white dolls. And in the end, the researcher says, why do you want to play with that doll? And she said, that doll is the one that's good, when she picked up the white doll. And they said, well, what about you? What do you look like? And then she has this struggle because basically she's been taught that white is good and black is bad. And so she wants to pick up the black doll because it looks like her, but that's the bad doll and she doesn't want to be bad. So again, I'd go and watch this video. But that's the kind of message that we send to our kids. They think about it, they bring it in, and then all the other people who see those images put it in the back of their minds as well. And that's how they approach things, even when they don't intentionally do so. So again, how does this impact all of what we do and what has happened in history? So many people realize that a lot of people of color mistrust the healthcare system, and they think, oh, well, Tuskegee, everybody learns about Tuskegee. But it's much longer lived than that, and it's ongoing. So Dr. J. Marion Sims, who was lauded as one of the godfathers of modern gynecological surgery, actually perfected his technique on women who were enslaved, obviously without their permission, without their consent, and also without anesthesia. Then in the 1930s through the 1950s, there was this huge eugenics movement that really what the idea was is to make the population more clean genetically by performing what they called Mississippi and Alabama appendectomies on women, which was no consent, but sterilizing these women. And again, this was through government programs, and this actually lasted up until the 1970s because it was couched as well, let's help these people with their contraception. And so even girls as young as 12 or 13 years old were actually sterilized without the real consent of their parents because their parents didn't have the medical literacy to understand what they were doing and consenting to. And we often think about schools and lunch counters being segregated, but it wasn't just schools and health or lunch counters. It was also hospitals and medical schools. So Black people weren't allowed to actually even attend medical school until the late 1800s. And therefore, there were fewer doctors for people to see. And if they wanted to go to the hospital, they were segregated because, God forbid, you'd have somebody who was Black or Hispanic next to you in a room in the hospital. So they were segregated. And so the care was less good because they had less funding for those hospitals. Of course, there was Tuskegee, where men were told that they were going to be treated for bad blood. And what happened was, again, government-funded healthcare people actually watched people's syphilis progress. And so some of those men died, some of their partners died. And again, this gets transmitted through the community, and you wonder why there's mistrust, where all of this history exists. Another example is Henrietta Lacks. She was a 30-some-year-old woman who was treated at Hopkins for cervical cancer. Her cells during her surgery were actually taken, again, without her permission, without her knowledge, without the knowledge of her family, and they were used for research. And then they were given out to other researchers. And then they were soon transmitted all over the world for other researchers to use. Again, no permission from her or her family. And you might think, well, that's all like a really long time ago, even though it's not that long ago. But this continues to happen every single day and right now. And people like to think of being poor and being of color as synonymous. And unfortunately, because of the legacy of slavery, there are huge wealth gaps between people who are Black and people who are white in the US. But even disregarding socioeconomic status, these occurrences still happen today. So hopefully most people recognize that that's Beyonce and Serena. And they have gone to the media and started to talk about their experiences. So obviously, neither one of them has an issue with enough money to go to good hospitals. But they still experienced really differential care during their pregnancies. And particularly Serena came very close to dying because she was ignored when she had a blood clot after her birth. And in this country, again, it's 3.5 times more likely for a Black woman to die after childbirth than it is a white woman, regardless of her socioeconomic status. So what are some other examples ongoing currently that are happening? So it's actually been known since the 1980s that if you have melanin in your skin, it's going to absorb more light and make the pulse ox readings less accurate. But how many of the medical professionals in this room knew that before COVID? Just a few. So it's been known since the 1980s, but it's not been taught. And so there's a great podcast, actually, if anybody's interested in listening, on nature.com, talking about this man who's dark skinned, and he went into the emergency room thinking he had COVID. They were trying to send him home, and he had read something online about pulse ox being inaccurate. And fortunately, he was able to convince them to keep him because he ended up in the ICU a couple of hours later. Another example is this Hoffman study, which, again, wasn't very long ago, where they asked medical students and residents about the differential experience of pain between Black and white people. They asked things like, oh, are Black people's skin thicker, and that's why they experience less pain? And what they saw is that, unfortunately, a lot of medical students and residents endorsed that belief that there was a difference in Black people's ability to feel pain. And it influenced whether or not they prescribed medicines for that pain. And unfortunately, medical schools, respiratory therapy schools, any field in health, I would argue, continues to perpetuate bias through the semantics that they use, through providing prevalence without context. So for example, saying, oh, asthma is so much more common in people who are black. I'm not saying, well, people who are black more often live in red line neighborhoods where they're exposed to particulate matter much more than people who are white. Also race-based diagnostic bias, as we have heard about CF, pathologizing race and teaching race-based guidelines. So we are contributing to the ongoing problem. So what is the impact of this? Aside from poor health outcomes, there's been a lot of work recently that shows that there's a strong association between the experience of racism and poor mental health and health outcomes. So telomeres are non-coding, sort of repeating sequences of the DNA at the end of chromosomes. And we know that chronic stress actually accelerates the shortening of these telomeres. And the rate of telomere shortening is obviously really critical to an individual's health and to their aging process. And recent studies have shown an inverse association between perceived racial discrimination and telomere length. So in addition to providing or not providing diagnosis and providing differential care, people are feeling this in their bodies in a real way and with their mental health. So another quote from a great physician or a great doctor, all the forms of inequality, injustice in healthcare is the most shocking and inhuman. So let's move to cystic fibrosis. I think it's really important. It was brought up several times over the last few days of the plenary, and Dr. Tullis acknowledged that there is more recognition now of CF in people of color, but it's important to realize that this isn't new. It's been there all along. So this paper is from Dr. Dorothy Anderson, when she described cystic fibrosis for the very first time in 1938. And this is a screenshot of her paper, where she specifically said that of the patients that she was describing, there was a black child and there was a Hispanic child. And she said the racial and geographic distribution of this disease is wide. But again, it has not been taught that way. So for the last 80 years, we have been taught that it's a disease that only occurs in white people, and that's had consequences. And so I understand that people think it just now is being recognized. It isn't just being recognized. It was not acknowledged. And now, as we start to look at this and people are acknowledging it, we realize that it does actually occur in people of all races and ethnicities all across the world. And these are the demographics here in the US currently. And so keep that in mind as we talk about some of the enrollment in clinical trials and other things. You'll see that they are disproportionate to the number of people who are actually in the population. So what has happened when we have actually ignored the fact that since the disease was described, that we knew that it occurred in people of all ethnicities and races? So as Dr. Macaulay's work has shown, most recently in a paper, I think that came out like 2 weeks ago, commonly used newborn screening panels will miss rare mutations in Black, Indigenous, and people of color. And also, a recent survey found that over half of State Department of Health websites refer to CF as a Caucasian disease. So that creates bias, and that means misdiagnosis for people of color. The other thing that Dr. Macaulay and colleagues showed that is even when a baby is picked up on newborn screening, has a positive newborn screen, if they're of color, particularly if they're Black, they're still going to be referred to see a pediatric pulmonologist 9 days later than a baby who is white. Again, that's bias, and it's affecting people's health. And what about adult CF? So people who present as adults with CF usually come in with pulmonary and sinus complaints rather than gastrointestinal complaints. They often have a functioning pancreas, and that's why. But they also often have less common variants and an indeterminate sweat chloride. But it's also really unlikely to be considered in someone who isn't white. And someone who Dr. Macaulay knows well, and several of you in this room know well, Mr. Terry Wright, was told, actually, you have all the signs and symptoms of CF, and I would think you had that if you weren't Black. again, a problem because he was 54 years old and had been misdiagnosed all of that time and undergone a lot of procedures that he probably could have avoided. It leads to increased morbidity. So Hamish and colleagues found that FEV1 was 3.9% lower, and weight for height percentile was 6 percentiles lower in black children with CF than in non-Hispanic white children with CF. McGarry and colleagues found that compared to non-Hispanic white people with CF, Hispanic people with CF acquired Pseudomonas at a younger age and had a higher risk of having chronic multi-drug resistant Pseudomonas, which of course is associated with worse morbidity and mortality. And then Fisher and colleagues demonstrated that black race is independently associated with later age at diagnosis and then consequently decreased weight for age. It's also a risk factor for death. So again, Dr. McCauley and colleagues used data from a large study of people with CF and the registry and found that the risk factors for death before the age of 18, there were 3,880 people with CF in this study, and about 5.7% of them died before they were 18. The risk factor, one of the biggest risk factors, was black race. And that was regardless of consideration of their lung function when they were younger. Also, thinking about lung transplant. So there are those with advanced disease, even with the current era of modulators, who need lung transplant. But recently, Kathy Ramos and colleagues studied survival and lung transplant outcomes for a really large group of people in the US and Canada. And what she found was that people in the US were likely to receive less likely to lead a lung transplant and more likely to die. That's because of our healthcare system versus Canada's. But that was particularly true if people were non-white. And then even more recently, Hayes and colleagues demonstrated that since the reduction in lung transplant because of Lex-Tezaiva or Trikafta, it's still lower for people of color. So that reduction in transplants that you see in that slide is fantastic, but if you're someone of color, you're not going to see that same benefit. So, with all of that, the very first step is acknowledging that this is still an issue. I said yesterday at the fireside, I literally have had people tell me, well, you people just need to get over slavery. Well, unfortunately, the repercussions are still here, and so we have to acknowledge that they're still here, and we have to start to address them. And in fact, both the CDC and the AMA have said, we acknowledge that racism is here, and it's a serious health threat. So once we acknowledge it, that's just the very, very first step. So what are some of the relatively simple steps that you can take? So one thing is reducing your own implicit bias. So Harvard offers this test called the implicit association test. And it really measures the attitudes and beliefs that, again, are ingrained in people from the time that they're very young that you're either unwilling or unable to report. And these implicit beliefs, they can impact everything we do, but particularly when interacting with people and patients through non-verbal behaviors like eye contact or avoidance of eye contact, errors in speech, and other things that you do that may convey dislike or discomfort. This training must include conceptual understanding and self-identification and ways to do behavior change and prevention. It's necessary, but it's not sufficient. You also need to improve your knowledge. As I mentioned earlier, what we were taught from the time we were in kindergarten up through now often leaves out a lot of the important details. The example I gave again yesterday was that think about when you were taught about the Constitution and taught about 4th of July and how that was a huge celebration. Hey, we're free. Black people were not free. Black people were still enslaved when that happened. And it's not taught that way, and so people just forget that that was the case. But that's a lot of the way things were taught. So educate yourself about some of these issues. Attend lectures. Thank you for doing that. And then ask your Black, Indigenous, and people of color patients, ask your colleagues about their experiences, and listen to them without invalidating them. So when that happened to Nick, that someone was basically ignoring him and assuming he wasn't the person in charge because of his color, don't say, oh, well, Nick, I'm sure they didn't mean it. I'm sure that it was, just listen to what he has to say and think about why it may have happened and why he thinks that it happened, and don't just try to override what he is telling you. The other thing that's really critical, and it's been shown over and over again in the literature, is the importance of representation. So while the number of Black, Indigenous, and people of color who are in medical school has risen a lot over the last 20 years, the number of people who are faculty has not, because there's a huge amount of attrition between medical school and actually becoming faculty. And the reason for that is because of the microaggressions and macroaggressions that Nick described that occur every day. Some of us just go for a long run or go play golf or do something to sort of brush that off. But others just decide that it's not worth it and they cannot deal with that every single day. So we need to change the culture of our institutions so that people do not leave, because you recruit them and then you treat them terribly and then they leave and they give up. We can't keep doing that. We have to change the culture of our institutions and the culture of medicine. So why does it matter? So there's data that shows that Black, Indigenous, and people of color patients actually may prefer and have better interactions with people who look like them. So there was actually a recent study that showed there were higher Press Ganey or patient satisfaction scores if there was race concordance between the doctor and the patient. There was also a study in newborns. So in the US, newborn infants are much more likely to die if they're Black than if they're white. But what they showed in the study is that for Black infants, if there was race concordance between the doctor and the patient, they were less likely to die. So it can really be an issue of life or death. Also, institutions that actually employ people of a given racial or ethnic group may seem more trustworthy to the people that they're trying to serve. So I would argue that that is the case, and that your faculty, your staff, they should be representative of the patient population that you're treating. Also, BIPOC medical students express a greater interest in serving the underserved, and they actually are more likely to do it. So the other thing that we really think needs to happen is that we need allies. Nick and I can stand up here and talk about this and we can do it, but we need help. We can't just be us. And it can't just be the folks that are on this panel. We need everybody to contribute to this. So if you're in a situation where there's a micro or macroaggression happening, like what happened to Nick, I mean, the medical student's in a little bit different, or the nutrition student's in a difficult position because she is not the person who's in charge there. But if you're in the room and you see that happening, don't expect the person who's actually experiencing the transgression to respond. It should be somebody else who steps in and says, this is a problem, we need to stop this sort of workplace culture, this interaction here in this room right now. Don't just sit there and be a passerby and watch it happen. So in conclusion, race is a social construct without biological basis. It often serves as a proxy for institutional racism. Historical and ongoing racism are integral to the social determinants of health, and they lead to health inequities. Historical and ongoing racism also, in this medical system, explains current medical system distrust, and it affects many Black, Indigenous, and people of color. We've got to fix that. Finally, acknowledgement of racism and its impact are a critical first step for critically assessing all that we're doing and addressing the causes of health inequity that still exists today. So with that, I'll stop and say thanks to all the people with CF and their families who are contributing to some of the research and some of the surveys, some of the feedback that we're getting to help us make change, all the organizations that are using their sphere of influence to actually affect change, and all of you for attending today, because obviously you're here because you want things to change as well. So thank you. Okay, apparently we're going to do questions right now.
All right. First question. Much of the current known disease burden for CF is in countries in North America and Western Europe. Since under and late diagnosis, non-Caucasian people is such an issue, even in these countries, do you think current estimates of the number of people with CF around the world are accurate? And if not, what can be done to address this?
You know, that's a great question, and we were talking about this in several conversations over the last few days. So I definitely think it's underestimated around the world. I have another example of a 34-year-old man who was from Bombay who came to me with Pseudomonas and bronchiectasis and infertility, and someone said, oh, well, maybe, I don't know, and they got like a 30 mutation panel and said, oh, well, you're just a carrier. And of course he had CF with like sweat of like 75. And unfortunately a mutation that was rare because we haven't studied mutations in people who are not white very well. But I was able to get compassionate use ivacaftor for him. But the problem is he was on a work visa. And so if he left the US, he was not going to be able to get it in India because they don't really diagnose CF there, or they haven't in the past. And I think part of the issue in some of the lower income countries is that there are other diseases that could mimic things that seem like CF, like TB is a problem in some of these places, and recurrent diarrheal illness. And so I think people are thinking about these other things, and they're thinking it only occurs in white people, and so they haven't established the infrastructure to even do something like a sweat test. But I know that the CF Foundation actually has a group of people that are working with going into these lower income countries and trying to help them set up infrastructure to at least make diagnosis and then sort of do at least basic treatments. Obviously, getting the modulators to them is a long way off since we haven't even barely gotten it in all of the countries that have healthcare systems that are different than that in the US. But it's a huge problem of underdiagnosing because we didn't recognize it until now, even though it's existed for a long time.
Thank you. Can you speak to how CF Foundation could use their privilege and resources to benefit people with other conditions like sickle cell anemia? Yeah,
that's another great question. Another thing that was said to me, I remember there have been so many things that have been said to me that made me think of a pause. So I was talking to somebody about the difference between the CF Foundation and what's happened with sickle cell, and they're like, oh, that has nothing to do with race. I'm like, really? I feel like it has a lot to do with race. So I think that we can use some of the technology that we've gathered, some of the sort of infrastructure, some of like the things like the registry. We can help with guidance, and sharing resources is one of the first ways that we could help. And also just, you know, again, acknowledging the fact that racism in medicine has prevented some things from advancing as much as they can. And I think even acknowledging the fact that CF occurs in people who are not white, I think is it's a wake-up call to other organizations and people across the world that they need to pay more attention to these issues and contribute, and not just to diseases that affect only people that are white, or that's what they thought they did.
Perfect. Can you speak to how, oh, sorry, it jumped. As pediatricians, how can we ensure timely diagnosis and appropriate interventions if we can't rely on newborn screening as previously believed?
Yeah, another great question. So I think that you reach out to people who are actually in leadership, like Dr. McCauley, who are trying to change how newborn screening is done, and you help advocate at the state level, because right now part of the problem is that every state does newborn screening in the US in a different way, and some ways are going to be more likely to be discriminatory against people of color than others. And so we need to find a way to standardize that. And so working with people in leadership, advocating at your state and local levels is a way to help with that.
Perfect. What are some other practical ways that people can begin to break down these disparities besides, of course, personal growth and education?
So again, I think that especially if you're in a position to hire, if you're in a position where you're teaching, making sure that you're passing along this information to the people that you're training, and challenging people when they say things that are completely inaccurate, that are race-based. I mean, we really have to stop teaching race-based medicine, but as we are getting educated ourselves, we can pass that information along. And when you're hiring, again, making sure that you're not just thinking about recruitment, but you're thinking about retention, because you're changing the culture of your workplace to make it more friendly to people who do not look like you or have your experiences.
Thank you very much. That's, it's been really impactful just hearing the first two speakers today. So I'm from Vancouver in Canada, in British Columbia. And there's been, over the last year or so, discovery of unmarked graves of children who were sent to residential schools in Canada, and happening across Canada, but also within British Columbia. And that really has started to trigger a change. It's a first step, but it's a truth and reconciliation. And so now for Indigenous partners on everything that is being done within the healthcare setting is engaging with those partners to make things which are culturally appropriate. And I think you hit the nail on the head. It is mistrust. People don't trust the healthcare system or what they're going to do. And so it's a long journey. And as you were saying, step by step on everybody's shoulders moving forward. So thank you.
All right, thank you so much.
Yeah, and I was like, thank you. Sorry, thank you for that comment, because one of the points that I didn't make that I've made previously, I think I was already going close to over time, is that it takes a long time to build up trust, a very long time. And you can erase all of that in an instant. So it's really important that you not only work on building up that trust, but also a space where if you say something that's really egregious, that you've made it comfortable for that person to say to you, hey, that was really hurtful, let's talk about this. Because as I think Nick alluded to earlier, I mean, a lot of people come into the office and they want to make us feel better. Like, they don't want us to feel badly. But if you do things over and over again, or even once after you had really worked on your trust, then that's going to really define the relationship all over again. And so make it a safe space, not just in this room, but in your clinic rooms, in your research rooms. Your patients really need to be able to let you know when you have made them feel really badly or you haven't met their needs. And so make those spaces.
Thank you.
Thank you so much.
So again, here are some additional quotes from the Communities of Color report. Again, asking you again to just listen to the words of the CF community. Reading the words of the CF community, and we'll have these for a couple of minutes, and then we'll introduce our next speaker. All right, we want to introduce our next speaker, which is Dr. Daniel Weiner. He is the director. He's the director of this, Antonio J. and Janet Poblano, messed that up, apologize, Cystic Fibrosis Center. And so I don't welcome to the stage.
Oh, there we go. So I want to, can you go back one? I want to thank Chandra and Chloe for inviting me to talk, and I'm not going to thank you for having me follow Nick and Jen, because they're tough acts to follow, really. I'm going to focus on a fairly narrow part of race in medicine. There's a lot of other examples, but I was asked to talk about how this has been used in pulmonary function equations. So one of the hats that I wear is the director of the Pulmonary Function Lab, as well as directing our CF Center in Pittsburgh. I don't have any financial disclosures, but I think I'm here because I have been a member of the ATS PFT Proficiency and Standards Committee, which has informed some of what I'm going to talk about today. So I want to just include some of the sources that I used to put this talk together and recommend a couple of them to you. One of them is a book that's called Breathing Race into the Machine by Lundy Brown, who's an anthropologist, and she's done some laboratory research as well. And it's really sort of a history about the use of spirometry and how race has impacted the use of spirometry over the years. And some of what I want to share with you today was part of a workshop that the American Thoracic Society convened about a year ago, when we were asked to try to address the use of race in pulmonary function testing. And so there was a report that was prepared, and it's under review for publication. And so I can't really share with you the final report, but I can share with you a little bit about what went into that. So that report workshop is being chaired by Nirav Bhakta from UCSF and Kristen Bleim, who's in Arizona. And there's a few other people on this committee that I've shown down here. And this is Lundy Brown, who authored the book that I showed you. I don't know if my pointer doesn't show up there, does it? All right, well, I'm pointing to myself. Okay, so why do we have reference equations in the first place? So one is when we see a patient, especially a pediatric patient who's growing, we need to take that lung function measurement, that vital capacity of 3 liters, and place it into the context of how does that compare to other healthy people? Is this a healthy vital capacity, or is it somebody who might have a disease going on? For somebody who's not growing over a short period of time, so for somebody in the hospital with cystic fibrosis who we're giving antibiotics and airway clearance to, we can look at that change and use them as their own control, and then we don't really need equations. So did your FEV1 go up or go down or stay the same? And you may not need an equation to figure out if they're getting better. But because height changes in kids fairly rapidly, and height affects lung volume because of the height of your thorax, then we came to learn that we probably do need to use some equations to decide how at least kids' lungs are growing or not. So I'm going to give you a little bit of old background about how some of these equations came to be. So this is Charles Thecla back in the early 1800s, who some people called the father of occupational medicine. And he published this little monograph whose title's impossible to read, so I'll read it to you. It was called The Effects of the Principal Arts, Trades, and Professions and of Civic States and Habits of Living on Health and Longevity, with a particular reference to the transit manufacturers of leads and recognition for the removal of many of the agents which produce disease and shorten the duration of life. You would never get away with a title like that anymore. But what he did is he tried to measure lung capacity with a very, very simple device, as well as symptoms. He was one of the first people to use a stethoscope. And he described this in these mill workers and soldiers and shoemakers. So he sort of categorized people by their occupation to some extent. In the 1850s, Hutchinson tested more than 4,000 people using a very early water seal spirometer. You can see some pictures of these old devices if you go to that pftforum.com website, and you can see some really old historical devices. And he classified people by social class, and he had them grouped as paupers, firemen, pugilists, which I think are boxers, sailors, gentlemen, dwarfs, and giants. And he found out that people that had a low breathing capacity had lower survival, and he created these tables, not really equations, but just sort of tables of numbers that he thought to be sort of in these healthy people, and it clearly varied by height. In the 1860s, during the U.S. Civil War, Gould in the U.S. Sanitary Commission went out and started using this little portable device to measure lung function in 21,752 soldiers that were white and black, some sailors, some students, some prisoners. And they also created these tables that looked a little bit like this one. This one I took from Dr. Brown's book. And you can see that they categorized lung function: white soldiers in the early series, white soldiers in the later series, sailors, students, full blacks, mulattoes, and Indians. And in this paper, he said Gould recognized that ancestry was difficult to categorize. 3 or more distinct races of Negroes are to be found in the southern states, and though these present themselves in every degree and mode of admixture with one another and with the Indian and white races. So even back then, they were recognizing that there's clearly a spectrum of what we might think of as ancestry or race. One thing that's also really hard to read on this table is that the measurements for the black soldiers were about 88% of the measurements of white soldiers. And in later years, some people used that difference as a fixed correction factor. So they would multiply values taken from white people by 0.88 and use that as a predicted value for non-white people. And this is sort of one of the very early sources of that, what was called race correction. It's not how things are done now, but that's one of the places that originated from. Let's jump forward a little bit to the 1920s. This is George Dreyer, who established reference values for lung function in England in the Royal Air Force. He also categorized people according to social class. Ruth Boynton was at the University of Minnesota, and she was the director of the public health department. And she found out that most women had lung function that would have been considered abnormal if you used men as the reference standard. And it wasn't until the 1950s that the Medical Research Council in the United Kingdom authorized separate reference equations for women, actually 1970s, I think. So it was the 1950s when they first started deciding maybe we should collect some measurements from women as well. So as you can see, if you go sort of back, white men were the reference standard for almost all lung function. And then only as we get into the 50s and 70s do women start entering the picture a little bit. So when people set about to collect data, one of the things that you would try to do is take people that you thought did not have lung disease, so a healthy population. And one question that I think is worth asking as you look at some of these other studies is, how do we define a healthy population and who belongs in that population? So in the 1970s, there's sort of an explosion of studies. This is C.D. Schmidt, who collected data that was used by the Intrathoracic Society in the 1970s, and he collected data in 820 Salt Lake City blood donors. That was the healthy population. Morris, which was the recommendation from the American Thoracic Society in the later 1970s, collected 963 volunteers from Oregon. And these were mostly white. Higgins, who did a study in Tecumseh, Michigan, had a collection of patients, 6,363 adults and children in Michigan. And Knudsen, which many of pulmonologists have heard of, in the 1970s, collected data in non-Hispanic white residents of Tucson. And some of these studies are pretty small, some of them are a little bit bigger, but they did not have lots of diversity necessarily. Also in the 1970s, OSHA recognized that there was cotton mills in the South that used spirometry as a pre-employment screen to decide if it was sort of safe for them to work in this mill environment. And although blacks were 35% of applicants, they were 80% of people that were turned away on the basis of lung function. And that made OSHA say, maybe we shouldn't be using white predictive values for black patients because we're turning them away in higher numbers, and maybe we need to scale the predicted values so that we're not turning them away as much. And that's sort of one of the early ideas about using adjustment to predicted values came from OSHA. In the 1980s, some more equations came out. So CRAPO became the new ATS recommendation in 1982. That came from a population that was 90% Mormon in Salt Lake City. Dockery, who has conducted something that was called the Six Cities Study, was sort of one of the first to use a little bit more complex equations to predict lung function. And that was a study from Harvard that was looking at environmental health. This is Bob Hankinson, who was very well known for investigating coal worker lung disease in West Virginia and a variety of other environmental diseases. And he created a data set using the National Health and Nutrition Examination Survey, the third edition of that. And he had a relatively larger data set, about 7,500 non-smokers that were categorized as Caucasian, African American, or Mexican American. And he had more complicated equations that had one set for people less than 20 and one set for people older than 20. So just this span of equations that some small data sets, some bigger data sets, and often without tons of diversity in them. So that brings us to 2012, where a collection of researchers got together and created what was called the Global Lung Initiative. And here, this was not collecting new data, but going around to collect existing data and trying to pool it to have a larger data set that could be more robust statistically. And so this is Philip Conjur, who's died a couple of years ago, who's from the Netherlands, and Sanja Stanojevic, who's from Canada, and who's a fantastic respiratory epidemiologist. And they collected data from lots and lots of different researchers. And so they have a data set that's almost 74,000 non-smokers that went from age 2.5 to 95. And they smoothed those equations, so it's one equation. The equations are quite a bit more complicated than simple regression equations. But I want people to recognize that of these 74,000 measurements, the vast majority are from white subjects. It's a much smaller number from African Americans, and these African Americans are truly African Americans. They're all from the United States. 5,000 Northern Asians and about 8,000 Southeast Asians. And so this modeling system that they used was called the Generalized Additive Models for Location, Scale, and Shape. And so they're, like I said, a little bit more complicated statistically to use. And the first paper was on spirometry, and they had subsequent equations on diffusing capacity and lung volumes. But I put a little asterisk because the publications for lung volumes and diffusing capacity are basically only from people of white ancestry. So they didn't feel that they had large enough sample sizes of non-white subjects. So these publication equations are only for white ancestry. And you can go on their website and you can read a little bit more about it. And the American Thoracic Society recommended a couple years ago adopting the Global Lung Initiative equations because of their sort of statistical robustness. So how do people go about thinking about developing a reference population? Well, there's some assumption that there's a spread of measurements. So some people have small lungs, some people have big lungs, and some people have medium-sized lungs. And so we think that this may be normally distributed, and you want to take measurements from a population that you think is healthy, but how do you define that? Is it just non-smokers? Is it people that never had a viral infection in their life? Is it people that never had early exposure to illness? So that's done in lots of different ways, as even in the Global Lung Initiative. And then there's other things that clearly affect lung function, but we don't measure in most of these studies that we would now call social determinants of health, things like income and air pollution and diet. We just don't have easy ways of describing that in most of the data that we already have. We know that the predictive values of lung function are probably affected by some of these variables, like hormonal influences on lung development and on the chest wall. Clearly, the taller you are, the taller your thorax is, and that affects your lung volume as well. We know that there's changes with age in lung function. And so one of the questions is, well, what about race and ethnicity? So this is a figure from the 2012 GLI paper, and they categorized the measurements according to these different groups that they called white, which are people from Europe, Israel, Australia, United States, Canada, Mexican Americans, Brazil, Chile, Mexico, Uruguay, Venezuela, Algeria, and Tunisia. As I mentioned, the blacks all came from the United States, and then Southeast Asian from a variety of countries, and Northeast Asian from a variety of countries. If you look really closely, there are some countries that don't appear on there, like Japan, India. So this is not covering the entire world. So it's called Global Lung Initiative, but it's maybe not as global as we would like. And also not very much from Africa, right? So as I said, most of the blacks are from African Americans. So one of the explanations about why there may be differences, or one partial explanation why there may be differences in some of these groups, is there is a difference between standing height and what we call sitting height, which is your height from your coccyx up to the top of your head. And that ratio of how much of your height is in your thorax possibly varies by different populations. And so this is a paper from Suki Lum from 2015 that shows that when they looked at this in children in London, so this is all in one country, that they did find sort of a different ratio of standing height to sitting height. And that, they thought, explains part of the differences between these groups, not all of it. On the other hand, when they looked at children in India, clearly there were some environmental differences. So people that lived in the city versus people that lived far away from the city versus people that lived partly in the city also had differences in lung function. So that's within just all Indian children. So there's clearly environmental effects as well. I think Jen kind of covered this, that race we really assume is a social identity that may be assigned to you by somebody else, like a hospital staff person. American Thoracic Society recommends that we ask patients to self-identify their race in the pulmonary function lab, but more often than not, it's a respiratory therapist looking at a patient saying, they look black to me. And that's not how it's supposed to be done, but that's how it's done in most places. Ethnicity may be more of a cultural identity linked by shared culture and language. And then there's ancestry, which may get more at genetic identity, like things like you can buy these kits from Ancestry.com or 23andMe that tell you where are you from. I had my wife got one of those many years ago, and she found out that she was 97% Ashkenazi Jewish and 2% Neanderthal, which we thought was not going to help our kids get a college scholarship. So, how do I define myself? Well, I define myself as a white person. My ethnicity is Ashkenazi Jewish, and I would say my ancestors are from Latvia, Hungary, and Poland. So we all have those sort of different kinds of the ways that we define ourselves, and there may be different degrees to how these things overlap with each other. But they're clearly not synonymous, and we can't use them as complete proxies for each other. And most peoples really have an admixture of ancestry. This is a quote from Harriet Washington, who wrote a book called Medical Apartheid, that said medicine is replete with examples of racial injustice inflicted by the use of race and ethnicity as biologic constructs to engender hierarchical discrimination. And so it's a great book, and I would highly recommend it. This is a study looking at genetic markers. This is Louisa Burrell, who's done a lot of publishing on using ancestral markers in lung function. And this is a population of Mexican Americans and Puerto Ricans, and looking at Native American genetic markers, European markers in yellow, and African markers in green, showing the huge diversity just even within a population that you think is pretty homogeneous. They are genetically not. And therefore, we really have to be careful about how we use these things. This is, I would say, one of the things that I took away from Lundy Brown's book. I think maybe one of the most important things is we don't know how to, if race is something, we don't even know how to measure it, I don't think. And so if you look at this, this is just a small spectrum of pictures of people with different skin tones. Race is, I'm sure, a huge continuum, and it's not a very categories that we can put people into very easily. And I think about when in the pulmonary function lab, we put children under this thing that we call a stadiometer to measure their height to within 1/10 of a centimeter. And so we're very, very precise about how we measure height. But how do we measure race? And if you could only measure height to the nearest meter, would it be a useful measurement? It probably wouldn't. So maybe race is not so useful if we don't know what we're measuring. This is a table from an editorial that the workshop authors put out before the workshop report has come out. But they said, pretend that you had a woman who's 47 years old, who's 167 centimeters tall, and her vital capacity was either 1.5 liters, 2.5 liters, or 3.5 liters. And if you look over on the right at these things that we call z-scores or standard deviation scores, this is one way of defining statistically what's normal and what's not normal. So we'll use negative 1.65 as the lower limit of normal. And you can see for the 2.5 liter vital capacity, which is the middle column, that her lung function is normal if you use African American predicteds. It's abnormal if you use white or Northeast Asian or Southeast Asian. Now, if you use the 1.5 liter vital capacity, it's abnormal for every single equation. And if you use the 3.5 liter, it's normal for every. So really, the choice of equations doesn't affect every patient. But if you're on the edge of normal or abnormal, it really can affect things quite a bit. And I want to give you just a couple concrete examples that are more cystic fibrosis related. So let's pretend we had a 60-year-old man, 6'2". He's currently taking Trikafta. He's interested in being in the Simplify study, which I think is now over. And his mom is from Kansas, and she's white, and his dad is from Kenya, and he's black. And to be in this study, you have to have an FEV1 above 60% predicted. So if you used, so his measured FEV1 is 2.13 liters. And if you use predicteds from GLI predicteds for African Americans, he would have an FEV1 that was 70% predicted. He would be eligible to be in the study. If, however, you said, well, mom's white, and he identifies as white, his FEV1 would be 59% predicted, and he would not be eligible to be in the study. And if you said, well, let's use the GLI other, which should be a more race-neutral kind of approach, his FEV1 would be 64% predicted, and he would be eligible. So this 6'2" 60-year-old man may have mild obstruction or mixed obstruction and restriction, depending on which equations you pick. So this is that 6'2", 60-year-old man. I'm pretty sure he doesn't have cystic fibrosis, but I made up some lung function measurements for him. And so you can see eligible or ineligible depending on which equations do we pick. So here's a 24-year-old woman, another example. She's 71 inches tall. She is interested in being in a modulator study. That's meant to look like a modulator study. And so to be in this study, you have to have an FEV1 that's between 40 and 90. And this young woman has a father who's from Haiti and identifies as black. Her mother's from Japan. She herself identifies as mixed race. So her FEV1 is 1.45 liters. Using African American predicteds from GLI, we get an FEV1 that's 41% of expected. Using Northeast Asian, because again, mom's from Japan, we get an FEV1 that's 36% predicted. And you can see now one of these falls within the range, one of these doesn't fall within the range. And if you used other, she's 38%, which doesn't fall within the range. So again, eligible, ineligible, depending on which equations you pick. That's Naomi Osaka, and as the 24-year-old 71-inch tall person. Now, those are two examples I gave you, but tomorrow walking into your PFT lab could be any one of these people who probably identifies as mixed race. And which equations are you going to pick? And how is that going to affect whether or not they could be in that clinical trial or something else? And it's something that we are trying to come to grips with as a PFT community. What about lung transplant? Well, as of just a couple years ago, lung function is actually not part of what's called the lung allocation score. So it doesn't really matter what your lung function is anymore in terms of whether or not, how quickly you will get a transplant once you are listed. However, it may affect about whether or not you're referred for transplant, because there often we are using percent predicted to look at when is it time to refer somebody. Now, in truth, we don't necessarily use these as rigid cutoffs. So if somebody's FEV1 was 51 and they're declining, we're not going to say, oh, it's not less than 50, let's not refer them. But it could affect how people are referred for transplant. And then I'm going to just wrap up real quickly with two ideas about how people have thought about this. So this is Aaron Bogg, who I think may have just finished fellowship in San Francisco, I think. And he looked at the relationship of lung function and symptoms in adults with COPD, so not CF. And he found that if that lung function and symptoms correlated better in African American and non-Hispanic white patients when you did not use race-specific equations, but you used GLI other instead of GLI African American or GLI white. So that the correlation of symptoms and lung function was better not using race. Another approach that some folks in UCSF have taken is to try to integrate the use of these genetic ancestry markers. So are you more European or more African or whatever? And that's a different approach. Clearly not something that's going to go into the PFT lab anytime soon, because we don't do blood tests with sequencing machines in the PFT lab. And then so I just want to close with, I know many people have seen figures like this before about the difference between equality, where we do the same thing for everyone, and equity, where everyone gets what they need. And I think I just tried to figure out how would I apply this to pulmonary function testing. So the reality is there may be differences between populations that are some mixture of social determinants of health and maybe some biological functions as well. One approach that would be equality would be using one equation for everyone and trying to make those equations as diverse as we can. Equity might be, again, having more inclusive data sets, I think. And really what we want in terms of justice is to have outcomes for everyone that are good for everyone regardless of what equations we're picking. So I think that's my last slide now. I'm sorry I went way over.
Thank you.
All right, so we don't see any questions that have come through virtually. Are there any, you have a question? Okay.
Mr. Kelly.
My question is, so you mentioned as race is not a biological thing, but even in the race examples, the lung strength was the 88%, when you mentioned it. So how do we correlate that information if it's not a thing, but there is differences? How do we utilize that information knowing, okay, there seems to be a race-based difference, but we are not using race to identify how we utilize that information as a scientific community?
Yeah, I think that's sort of kind of the million-dollar question. I think what we are moving towards is to try to say we're going to not use race in the equations, that we're going to use so this GLI, I guess I used the term GLI other and I didn't explain what that was. So I apologize. So in the GLI paper, there's this separate equations for white, black, North Asian, and Southern Asian. The other equation, which they constructed, is basically a mathematical averaging of those other four groups. So the problem with the GLI other, though, is that most of the people in the GLI data set are still white, right? 57,000 of the 74,000 are white. So I think we need to find a way to bring in other more diverse representation into that data set, and then we won't need to say what's your race when we use the equations. I think that that's going to mean that there's going to be sort of broader standard deviations, and there's going to be a little bit more fuzziness at the differentiation between normal and not normal, or healthy and disease. It's going to be a little bit fuzzier, and we're going to have to learn to live with that fuzziness, but we'll probably take race out of that.
All right. Thank you.
Thank you.
All right, and here are some more quotes. Category trustworthiness. All right. So we know that when we are working with our patients and families, they are more than just CF. And we have to remember how that affects the care that we provide them. We have 4 wonderful panelists that are going to join us for a Q&A, but before that, we're going to show you video of them sharing their lived experience. Now, when you watch these videos, I want you to think of them as your patient and family at your center, because it's so easy for us to look and go, oh, that center did that, or that center made that choice, instead of thinking about how we all are a part of the change and how do all of us make sure that certain things don't happen at any center. And the only way we can do that is to take ownership as if it is ours. So when you are listening to these patients and families, they are yours. So what are you gonna do to make it better the next time? Our first up is Elizabeth L. Kellner. She's an adult living with CF.
Good afternoon, everyone. I am Elizabeth Kellner, and I am a 40-year-old Hispanic American patient with CF living in Miami, who also had a double lung transplant in 2007, followed by a kidney transplant in 2011, thanks to my husband, who was a donor. My life beyond CF consists of being a daughter of 2 immigrant parents, a biracial woman, the only one in my family with CF. I am the youngest of 5 siblings on my mother's side and 4 siblings on my father's side. I am currently married with no children. I love to travel and learn about different cultures. I also love to do yoga, but I'm limited on what I can do physically. I am constantly not seen as a person with an illness because I look physically healthy. And I always feel I'm not allowed to have bad days, and I always push myself. I am currently struggling with body image since I've gotten older, and I struggle with mental health and anxiety. Constantly advocating for myself in the medical field when it comes to insurance and services has always been a big struggle for me. And also, now that I've turned 40, I'm learning how to navigate life and health after 40 years old. Also, I always feel that I am not being heard when I'm in a group of people, and I constantly feel the need to repeat myself or just not share what I need to say because I get frustrated because I feel I'm not being heard. 3 ways that I feel 3 ways I can challenge my CFT is to be culturally responsive. I think having a good and open communication to make families and patients feel at ease where they can talk to their team about any concerns is extremely important. Not making a patient feel dismissed or ignored as if they have no idea what they are talking about is important. As a Hispanic female patient, it is already a challenge to be heard today, and you don't want patients to feel that way when it comes to the health and a team that is supposed to be a safe place for patients to share and talk about their health concerns. One example that I experienced personally was before I was diagnosed with kidney failure. I was never told of the risk of my kidney function, and it started to decrease. It wasn't until it was too late, despite sharing my symptoms numerous times, that I went ignored. Also, being supportive of diversity in the CF community, which is currently growing, is also very important. Having the same resources and educational materials that are offered in English available in other languages for non-speaking English patients and families. Offer the needed support for families and patients that have a language barrier by providing needed translation services. But by being able to communicate effectively will help improve the patient's ability to have better and quality care. I also experienced this early on in my childhood when I was first diagnosed at 4 months and a half of birth. My mom did not speak English, until this day does not speak English. So I have seen her constant struggle in trying to understand not just CF in general as a parent, but also understand my doctor's plan of care, as well as any medical issues or conditions that have been presented throughout the years, especially during the transplant process. She had a very hard time communicating with my doctors and my medical team when I was in a coma and I could not speak for myself, and she had to be an advocate for me, constantly trying to get a translator, or the doctors themselves trying to explain to her there was a big language barrier amongst the two of them. And last but not least, I think offering assistance and guidance to non-English speaking families and patients when navigating medical care and needed services with insurance that are important to improving the quality of life and care for the patient. Patients and families have had challenges and difficulties trying to obtain necessary and sometimes often basic needs and assistance programs due to language barriers and lack of knowledge on how to navigate through insurance and benefits. It is important that challenges and barriers between these are addressed by the CF team to offer patients and families the needed care, especially those who are minorities that lack the knowledge to know what programs and resources are offered in their community through government insurance, nonprofit programs, and private insurance. I feel that this is also a big hindrance in CF care for patients and their families. A lot of times minorities are not aware of the types of programs, grants, nonprofits that are out there to provide services and assistance when needed. I've seen throughout the years in my community, especially the Hispanic community, a lot of patients that have come from overseas for medical care here in the United States, and they're not aware of such programs or insurance benefits such as Medicare or Medicaid that they may possibly qualify for. And they find themselves constantly fighting a system where they have nowhere to turn and no one to advocate for them, a lot of times because of lack of knowledge or language barriers as well. My whole life, I have had to fight the insurance system, whether when I had Medicare, when I had Medicaid, and even with private insurance, to get them to understand the basic needs and care of me needing for CF treatment. Simple things such as fighting for certain medications. When I had a feeding tube, I had to fight to get my formula for the feeding tube. It's always been a constant battle and challenge. And when there's a language barrier and lack of understanding and knowledge of how these systems work and what they can offer, it puts a huge hindrance on the quality of care of the patient as well as their families emotionally.
All right, and this is Melody Cheney. She is an adult living with CF. She is also a parent of a child with CF.
Hi, my name's Melody Cheney. I'm 37 years old. I have 4 kids. Never been married. I have CF. I have one of my kids, my oldest one, has CF also. I am a mother of a biracial daughter. She's half black and half white, and which is kind of odd for, you know, usually CF is a white people disease, but her father had the gene and passed it on to her. I myself am bisexual. I'm a mother of a bisexual daughter because she surprised me earlier this year. I found out she's bisexual as well. We've had some stuff we've had to go through with mental health as far as that's concerned with her. She's gone through some depression at the age of, I believe she was 10 whenever she started talking about, you know, suicide, just threatening to kill herself. And I've been in some foster care growing up. I didn't have a very good childhood growing up at home. What they ended up doing is they ended up putting me in a foster care, and I ended up being abused in the foster care. This was before I was diagnosed with CF. I actually wasn't diagnosed until I was an adult after my daughter was diagnosed. I had never even heard of cystic fibrosis until my daughter was diagnosed with it. And then I thought, I'm showing some of these same symptoms. So I insisted the doctors test me, and they tested me and confirmed that I did have CF. But as a kid, I wasn't diagnosed. The foster parents ended up telling all of us foster kids, if you want to leave, you can leave. We're not going to force any of you to stay. So I told them I wanted to leave, and they sent me back to my parents' house. And that didn't last too much longer because my mom ended up sending me up to Iowa to a boarding school. So I went there for my senior year. And that was a unique experience. I had a lot of good experiences there, but also a lot of bad. You know, there was a little bit of mistreatment. So I had a really rough childhood, but now that I'm grown and, you know, able to choose who I live with, I've had a pretty good life, and got some really awesome kids, 4 kids who love me. I want to add my experiences dealing with CF with my daughter. It's been a real struggle. When she was a baby, I had CPS called on me, and they were accusing me of neglecting my daughter, not feeding her and not giving her medicine because she's so small, and you know, she's malnourished. So they just thought that I must be doing something wrong. Of course, CPS was already in contact with her doctor and the CF clinic there. They contacted them to let them know that I had a case open and ask them, you know, questions about, do they think I'm taking care of her right, yada, yada. Her doctor there was saying, we're going to have to increase her enzymes because she's not gaining enough weight. So I just asked him a question. I said, okay, well, the Dallas clinic told me that she was already at the top of her enzymes and she can't take anymore. It can destroy her liver. So is that correct? Is that true? And just because I asked him the question about it, just trying to understand, he got very irate with me he raised his voice at me and was telling me, I've been in practice 30-something years, and I know what I'm doing. And so he just felt like, it seemed to me like he felt like I was questioning his intelligence, and he took offense to that. CPS became in contact with him because they wanted to let him know I had a case open and ask him how he thought that my care was for her. And so he told CPS that I'm refusing to give her enzymes, which is never what I said. But he told them, oh, she refused to give enzymes. And also there was a communication barrier because he didn't speak English very well. So because he told CPS that I refused to give her enzymes, then they told me, they said, your daughter can't remain in your care anymore. We're going to have to remove her from your care. When she gets released from the hospital, she's not going with you. They said you have two options. You can either find someone, a friend or a relative, who will take custody of her and agree to raise her, or we're going to put her in foster care. So I was beside myself. I didn't know what else to do. I thought I had no other option. So I called all my friends and relatives, and I finally found a neighbor who was willing to take her in. And when I was about to sign the paperwork to release my custody, I just stopped. I said, I can't do this. I'm not going to do it. And it's a good thing I didn't, because when she got out of the hospital, she was released back to me, and I still have my daughter today. That was when she was about 9 months old. Now she's 13 years old, and she's still in my care, regardless of the struggles I've had to go through along the way trying to keep her. So that was my first struggle. That was my first CPS case. I had another CPS case later on when she was about maybe 5 years old, maybe 4. I had fed her breakfast, but it had been a couple hours. And when I dropped her off at the babysitter's, she said, I'm starving. I haven't eaten all day. So the babysitter called CPS and told them she doesn't think I'm feeding her because she told her she hadn't eaten all day, and she's really tiny for her age. She's small. She looks malnourished. I got another case open. So, and the same thing happened where they were just threatening to take her away. Even though I took pictures of all the food in my cabinets, all the food in my fridge, and I even took videos of her eating or me trying to feed her, but she's refusing to eat because it was so hard to get her to eat at that age. The only thing she wanted to eat was ham and cheese sandwiches, and cereal, but it was so hard to get her to eat. Well, I made it through that CPS case, and even though they harassed me for a long time, I made it through, and they found me not guilty, and I was able to keep my daughter. Okay, so some things that I think that need to be changed or that CF clinics can do better is, like for example, the situation that I had with that doctor while my daughter was in the hospital. He just got irate with me because I asked him a question because I was just trying to understand. Doctors need to understand that patients need to be allowed to ask questions, and doctors need to listen to the patient's concerns and address those concerns without getting a temper and without letting their ego get in the way. So I really think that CF care all the staff in the CF clinics, the doctors, the nurses, the social workers, everybody, they need to let their ego go and realize that they're not the king of the world. They're nobody's boss. And they need to listen and answer questions without judgment. And if they think that there may be some type of neglect or abuse or something like that going on, then they should ask questions and make sure, before you just go and tell Child Protective Services that this parent is doing this or that, don't just assume. Make sure you ask questions first. If that doctor thought that I was going to refuse to give her enzymes, he could have asked me. He could have said, so are you saying, whenever I asked my question, he could have came back with, so are you saying that you're not going to give her enzymes? And I would have made it clear, no, I will give her enzymes. I'm just trying to understand why we're increasing them, And that could have all been cleared up so easily through a simple conversation. So CF team members need to have these conversations with their patients instead of jumping to conclusions or letting their anger or their egos get in the way and then just trying to take it out on their patients because their patient said something that made them mad or whatever. Think about, these are people's lives that are in your hands, and you need to be responsible with that.
And this is Erin Fortner, a parent of a child with CF.
Hi, my name is Erin Fortner, and I have an almost 14-year-old son with CF. My son Toby also has ADHD, and he is transgender, which means that he does not identify with the gender he was assigned at birth. All of these things, influence his life, play a role in who he is, and all of these things need to be taken into consideration when dealing with his CF, because they all influence his behavior and his mood and everything about him. 3 things that I challenge CF centers to do to be more culturally responsive is, number 1, believe your patients when they tell you who they are. Believe their experience and the way that they see things. Trust that what they're telling you about their experience is true. And number 2, leave judgment at the door. Whatever your personal or religious, cultural, political affiliations are, there's no room for judgment in the doctor-patient relationship. And number 3, and this is especially important for my son, but I think it's really universal, address your patients the way they want to be addressed. So use the proper name and pronouns. I can't tell you how important that is. What that tells my son is that you see him for who he is and for all that he is. And that is going to make him trust you and know that he's in a safe space. And that'll make your doctor-patient relationship so much better. And in turn, that'll make, the care of your patients so much better.
And David Hansen, parent of children with CF.
Hi, my name is David Hansen. I'm happy to be with you today. I am a father of 2 daughters, both with CF. My oldest daughter is 20 years old, and she's in college. My youngest is almost 15, and she's a freshman in high school. So we've been working with CF for quite a while now. My youngest was diagnosed at 2.5 years old. My oldest was diagnosed at 2.5. My youngest was diagnosed at birth. Really glad to be able to talk about some cultural competency and cultural considerations within the CF care space. I've thought about this a lot and wanted to share some thoughts with you. So as a father, one of the first things that came to mind when I was preparing for this is, thinking back on my experience, when my daughters were young, we would go to clinic all together as a family. Me, my wife, both my daughters, and I would go in, and it was really interesting. I just kind of felt pretty invisible to the care teams. And my wife's she's not my ex-wife, but she's very outgoing, and we'd walk into the room, and the nurse and the doctor, and they're giving hugs, and they're like, "Oh, it's so great to see you." And then they'd turn to me and go, "Oh, hi, Mr. Hansen." And it was just, it was just this kind of very different, feeling towards me. And I get it, they were right, their mom, my daughter's mom, was the primary caregiver to them, and she handled a lot of the CF components. So she had a lot of the information, but she didn't have all of the information. And it just kind of gave me this feedback loop of, I'm not really needed. I'm not really important or part of the conversation. So there's no point in me engaging in it. And it was frustrating. And then the result and then the downside of that later on is when, later when we did get divorced, and so there were times when I would just take the girls to CF clinic, we didn't have that rapport, and we didn't have that connection built. And, certainly some of that is on me, but the care teams, I just never felt like we connected and engaged in a way that was, a way that I felt welcomed and safe in that space. And now we're at a point where I have full custody of my youngest daughter, and it's been quite a learning curve to pick all that up and have complete control of her, or complete participation in her CF care. And I can't help but think the learning curve for me would have been lower if I could have been engaged the whole across the years through the whole process. Again, a lot of that is on me. I get that, and I've been happy to pick this up and help my daughter with her CF care. But it's just, the main thing is those times when we'd walk into the room and people were ecstatic to see my daughter's mom, and then would just turn to me and kind of just go, "Oh, hi to you too, sorry." And the difference was clear. So just something to think about as you engage with families, and because you never know how the circumstances are going to change, and that's so something to think about there. The other part that I want to talk about is my daughters both identify as being part of the LGBTQIA plus community, and I have seen at times when we come into to clinic and we'll be talking with a doctor, and there's just a lot of assumptions made about who my daughters are and what their interests are, and what and their personalities, and who and their sexuality, to be frank. I mean, we were sitting there talking to a doctor the other day, and he was asking, we were doing a little banter, and he was asking, he's like, "Oh, you're a freshman in high school. That's great. You're about old enough to start dating all those boys." And, and she just kind of shifted uncomfortably. And, you know, kind of was like, yeah. And I was like, and it just struck me how much of an assumption that was, that here's my daughter sitting on the exam table, but, you know, he just made an assumption about who she was and what she was interested in and the kinds of things that she wanted to be doing with her life. And so, you know, it's interesting. And another thing about our family is we were very religious at one point, but we have since left religion. And it's not something that we are interested in at all. So again, there have been times when they've asked us about church, or they've, you know, trying to have these small little banter conversations and find out about us, but making assumptions about whether that we go to church at all. And so, you know, the main takeaway for me across all these experiences has been, if only we had been approached with no assumptions and just with curiosity, that, you know, we could avoid these feelings of being uncomfortable. I mean, there was one time where my daughter, a nutritionist came in and said something, and it upset my daughter so much. She texted me on her phone. You know, she's like, I can't talk to her anymore. Can you please have her leave the room? And it got to that point where she was so upset and triggered that she had to ask the nutritionist, so that I had to ask her to leave. And I was like, I think we need to be done and just move on to other topics. And so, you know, it's important, and it makes a difference, because it completely shut my daughter down, and she could no longer hear anything that the nutritionist was trying to say about, you know, encouraging us to eat and different things. So it makes a difference when patients feel safe and when they don't. So anyway, that's me. Thanks for listening. Hope, and yeah, thank you.
All right. And we're going to pull up our lovely people, and the lovely David is here with us in person. So, any questions for our panelists?
Okay. I'm behind. Hold on just a second.
I didn't want to use the microphone. Hello. I'm in child life, and I do try really hard to utilize open-ended questions so I don't make the assumptions. So tell me about this. What do you think about that? A lot of the who, what, where, why, instead of, oh, you're interested in this person or this topic. But I would love to hear from the parent and caregiver perspective, what are some phrases that team members have asked that have been really effective for you and your child to participate really freely or safely. So I really am looking for concrete phrases that you have been like, oh, that was a really easy way to understand, and I feel really ready to share anything.
I guess I can go first. Can you all hear me?
Yes.
Okay, I have a wonky internet connection. The biggest thing for my son is to either introduce yourself with your pronouns or ask his pronouns. Because when you do that, it tells him that he's in a safe space, and he is much more free to be who he is. So that would be, for him, that would be the number one thing.
I think my feedback is,
very effective. I think the thing that comes to mind for me is stay in your lane. Like, if you don't need to ask a kid about, I keep going back to that example of, you know, the doctor made this assumption that, you know, oh, you're a freshman in high school, you're probably dating a lot of boys now. Like, was that necessary at all for her CF care? Like, no. Like, let's stay in your lane. Like, just keep it relevant and keep it short. Because we're all trying to make it shorter. I don't know, that's my thought. It's so long.
Any other questions?
Well, if no one else is going to ask, I'll ask. So after this session, are you guys feeling more or less concerned about your care team's ability to do better at this?
I'll just speak. I haven't really had a problem with this particularly, so that's why I'm being quiet on this one.
I'm sorry, can you repeat the question?
I was just asking that after hearing all of the speakers and all the discussion today, whether you're feeling more or less positive about your team's ability to be more sensitive in their care.
Looks like it froze. It froze. Well, it looks like we're having some technical difficulties. So I don't know. Oh. And we lost them altogether. Well, well, they're trying to bring them back live, but we definitely want to say thank you. Thank you, thank you, thank you for staying till the end. We know it's been a very long week. We know that you have tons of information you're walking away with NACFC, probably busting at the seams. All right, we got them back. All right. So, did you hear the question, Elle?
No.
No? Okay. So, they said it was just pass on the question. But, again, as I was saying, we want to really thank you for coming this afternoon. What was shared today was definitely shared from the heart. We are hoping that you walked away, we hope you are walking away with practical strategies, practical things that you can do to be a part of the change. Again, as Nick said again, it's one encounter at a time. You know, we think about diversity and equity and inclusion. I don't know why I've all of a sudden got this going on with my throat. But we think about it sometimes through the lens of only race and ethnicity. But our challenge today was really to look at it from a bigger global standpoint, right? Global in the sense that there's so much more. So we're really hoping that, again, if something touched your heart, touched your mind, walk away with it. And we're hoping that you use that not only in your clinical care, but just thinking about our everyday interactions, because no matter who we see, that person is more than meets the eye. So again, thank you, thank you, thank you. Thank you.
And a big thank you to our speakers as well as our panelists. You guys were amazing. Thank you for sharing.